You know what keeps me up at night? It's not the long shifts or the emergency surgeries or even the difficult cases. What really haunts me is seeing patients come into my office asking for procedures that I know deep down in my professional soul are completely unnecessary and potentially harmful. And here's the kicker. When my own parents asked me about some of these surgeries, I looked them straight in the eye and said, absolutely not now, not ever. I'm Dr. Clarence Martin. I've been a surgeon for over 15 years, and today I'm going to share with you the 5 surgeries that I would never, and I mean never, recommend to my own parents. And trust me, if I wouldn't recommend them to the people I love most in this world, you need to hear why before you or someone you care about considers going under the knife before we dive deep into this. I want you to understand something crucial. I'm not here to bash my profession or scare you away from necessary medical procedures. Surgery saves lives every single day. I've seen miracles happen on the operating table, but I've also seen the other side, the unnecessary interventions, the complications that could have been avoided, and the regret in patients' eyes when they realized they didn't need that procedure in the first place. This video isn't about medical gatekeeping. It's about informed consent. It's about you having the knowledge to ask the right questions and make the best decisions for your health. So let's start with surgery number 1. And this one is probably going to surprise you: vertebroplasty and kyphoplasty for compression fractures. Now, I know what you're thinking, Dr. Martin. Those are big medical words. What are you talking about? Let me break this down for you. These are procedures where surgeons inject cement into fractured vertebrae in your spine, usually in older adults who have compression fractures from osteoporosis. Sounds reasonable, right? Fix a broken bone with some medical cement. Here's the problem. Multiple large-scale studies have shown that these procedures work no better than a placebo. That's right, patients who received a fake procedure where doctors just numbed the area but didn't inject anything had the same pain relief and recovery as those who actually got the cement injection. When my mother, who's 72 and has osteoporosis, had a compression fracture last year, 3 different surgeons recommended this procedure to her. She called me in tears, in pain, asking if she should do it. I told her what the evidence shows: the natural healing process for these fractures, combined with proper pain management, physical therapy, and treating the underlying osteoporosis, gives you the same outcome without the risks of surgery. And there are risks. Cement can leak into the bloodstream. You can have infections. You can have nerve damage. And you're still going under anesthesia, which at her age carries its own set of complications. My mom did conservative treatment, wore a brace for a few weeks, did her physical therapy, and 3 months later, she was back to her normal activities. No surgery, no cement in her spine, no surgical risks. The second surgery I would never recommend to my parents is something that's becoming increasingly popular, and that's arthroscopic knee surgery for osteoarthritis. This one hits close to home because my father, who's 68 and was a runner for most of his life, has pretty significant knee arthritis. He was having pain, stiffness, the whole 9 yards. His orthopedic surgeon suggested arthroscopic surgery to clean out the joint, remove some loose cartilage, smooth things out. It sounds logical, right? Go in there, clean house, and the knee should feel better. But here's what the research tells us. And this is based on numerous randomized controlled trials, which are the gold standard in medical research. Arthroscopic surgery for knee osteoarthritis provides no better outcome than physical therapy alone or even sham surgery. In fact, one landmark study published in the New England Journal of Medicine showed that patients who had fake arthroscopic surgery, where surgeons just made the incisions but didn't actually do anything inside the knee, improved just as much as those who had the real procedure. Think about that for a second. The benefits people experience are largely from the placebo effect, the natural healing process, and the physical therapy they do after surgery. Now, I'm not saying arthroscopic knee surgery is never appropriate if you have a specific mechanical problem like a meniscus tear in a younger person with an otherwise healthy knee. That's different. But for run-of-the-mill osteoarthritis, which is what most older adults have, surgery isn't the answer. When my dad asked me about this, I set him up with an excellent physical therapist. We optimized his weight, got him on some supplements for joint health, switched him from running to lower impact exercises like cycling and swimming, and adjusted his pain management. A year later, his knee isn't perfect, but he's functional, active, and most importantly, he didn't undergo an unnecessary surgery with all its potential complications, like infection, blood clots, and the very real risk of anesthesia at his age. Moving on to surgery number 3. And this is one that makes me particularly frustrated because I see it recommended far too often: spinal fusion for nonspecific lower back pain. Lower back pain is one of the most common complaints in medicine. Almost everyone experiences it at some point in their lives, and when that pain becomes chronic, patients understandably become desperate for relief. Enter spinal fusion, a major surgery where 2 or more vertebrae are permanently joined together, eliminating motion between them. The theory is that by stopping movement in a painful segment of the spine, you eliminate the pain. Here's the reality for most cases of chronic lower back pain: without specific structural problems like spondylolisthesis, where vertebrae slip out of position, or spinal instability from injury or tumor fusion surgery, has very mixed results. Studies show that many patients don't get significant long-term pain relief, and some actually end up worse off than before surgery. Why? Because when you fuse part of the spine, you put extra stress on the segments above and below the fusion, which can lead to accelerated degeneration and more problems down the road. It's called adjacent segment disease, and it can lead to more surgeries in the future. On top of that, spinal fusion is a major operation. We're talking hours in the operating room, significant blood loss, long recovery periods, potential complications like infection, nerve damage, failed fusion where the bones don't properly heal together, and chronic pain at the hardware sites. The risks are substantial. When my parents asked me about back pain and what they should do, I emphasize the importance of a comprehensive approach. First, physical therapy focusing on core strengthening, and flexibility, addressing any weight issues, looking at ergonomics in their daily activities, sometimes targeted injections for specific pain generators, medications, when appropriate, and lifestyle modification. Surgery should be the absolute last resort when conservative treatments have truly failed, and there's a specific structural problem that surgery can address. Now let's talk about surgery number 4, and this one affects a lot of women. So pay close attention. I'm talking about hysterectomy for heavy menstrual bleeding without first exhausting all other options. Hysterectomy is the removal of the uterus, and it's one of the most commonly performed surgeries in women. Don't get me wrong, there are absolutely valid reasons for hysterectomy: cancer, severe endometriosis that hasn't responded to other treatments, large fibroids causing major complications, uterine prolapse. But too often I see hysterectomies recommended as a first or second line treatment for heavy periods or pelvic pain. When there are many less invasive options available, the thing is, removing an organ is permanent and irreversible. While modern surgical techniques have made hysterectomy safer than ever, it's still major surgery with real risks: infection, bleeding, damage to surrounding organs like the bladder or bowel, blood clots, complications from anesthesia, and long recovery time. Plus, even when the ovaries are left in place, some research suggests hysterectomy might affect ovarian function and hormone levels, potentially leading to earlier menopause. What troubles me is that many women aren't fully informed about alternatives before surgery is recommended. There are hormonal treatments, IUDs, that can dramatically reduce menstrual bleeding, endometrial ablation, which destroys the lining of the uterus without removing the organ, medications that can control bleeding, and treatments targeting specific causes like fibroids or polyps.